KSOGA President Dr. Rajeshri Paladi to start the pedagogy event for the postgraduates, which is going to help them for their examinations. So, as a dream come true, we are going to start the first event today. So, we have chosen actually, we had chosen six, but MMC, some communication, it has dropped out today. So we are going to have five colleges, Raichur, Kalburgi, Mangalore, Hubli, and BMC. So all the HODs and the students, they have given a very good response. So depending on the first event, next we are going to improvise on this, whether to add on more colleges, more students, more topics. So as a example, and we are setting an example today to start this. So
Manjula,
I
start with
welcome.
the prayer, dear.
Yeah, I welcome one and all, and I request Arun to start the lamp lighting. Thank you, Arun, for the divine uh, light lamping. Now I request our President, Dr. Rajeshri Paladi, to address the gathering.
Namaste. Good evening, everybody. And it gives me immense pleasure and very happy to know that the pedagogy which we all had thought of has been commissioned in the KSOGA. This is basically an endeavor to help the students participate and be the teacher, because we know that now, according to the NMC, the CBME, that is the communication-based medical education, is of prime significance now. And of the various methods of learning that we have, one of them is pedagogy, wherein the student also becomes a teacher, and it also helps them to assess the amount of learning that they have got from this efforts. So we have small group discussion, we have bedside clinics, we have journal club reading, and apart from that, in pedagogy, given in the 5 minutes of the topic, that the student will have to assimilate and present whatever they have learned and whatever they have understood about the topic in the given point of time within the flash of a minute. So I hope that this endeavor will be taken well. And since this is a first attempt, I think we have had our learning curves, and from as Manjula has ensured that we will make that this becomes a very streamlined effort. And I must say that Dr. Manjula has put in a lot of effort, lot of um, thought process into this since nearly 2 months now, that we have been working on the various aspects of how we can commission this and how to make it effective. So we'll make sure that every month we have one designated week. We choose to have it on a Monday, the first week of Monday, first Monday of every month, so that the postgraduates can be prepared and geared up. And we can also talk to the head of department to ensure that the postgraduates participate well. From now onwards, we'll also have a competition amongst the postgraduates, so that it becomes a incentive for them to learn well and present well. This is a little different from the case presentations that we used to have, but we also know that pedagogy is an important aspect in the clinical presentation, and a good amount of scoring can be achieved by doing the pedagogy topics. And we choose to give them the topics. At least 5 topics will be given to the students, and only from those topics we'll be picking up the chits and student will be asked to present on whatever topic is given. So this is the pattern that we have formulated, and I see that a good number of participants have logged in. Since we have only 5 medical colleges now, and in the future we ensure that more of them will be participating in this process. And I thank you very much, Dr. Manjula, for taking this initiative and carrying it forward. What plans we had and what dreams we had for the KSOGA in my tenure. So Manjula was the perfect choice because she is also a professor in the medical college and she understands the concept of what we are doing. Thank you so much, Manjula, and also welcome Dr. Shobha Gudi, Secretary, Honorable Secretary of KSOGA, and Dr. the faculty of all the medical colleges, the professors, the heads of the department. And I thank the heads of the department for complying to our concept and sending and recruiting their postgraduates for this. And I also welcome the postgraduates who have joined in. Let's all enhance our learning, because for PGs, having the precision knowledge is very important, and especially the basics. So now with the current era of trends of learning very much advanced things, like we have gone even to molecular level of genetics of understanding the concepts of disease, but nevertheless we should never forget that the basics are the ones which go with us for our help towards the clinical care in the patients. So postgraduates, we look forward for any suggestions from you and any inputs from you, and in what way we can make it more interactive and better learning process. I thank Arun for being there all the time and welcome everybody for this learning process. Over to you, Dr. Manjula.
Thank you,
Manjula,
ma'am.
I'll
Thank you.
just take a minute, dear. I'll just take a minute. I'll just take a minute. I congratulate you. And first of all, I congratulate Dr. Rajashri Paledi. What an excellent tenure her presidency is. And, we are having milestone after milestone being achieved. I'm very proud to be her secretary, though she is younger to me. She's really made a lot of effort to see that her presidency makes a mark. Thank you for doing that for KSOGA, Rajashri, and for all the 24 societies. They're indeed lucky that you are the president this year. Now, for the postgraduates, I think this is a very novel program. I think each postgraduate who has joined should spread the word to more and more students, all your colleagues, all other institutions. Every teacher who has joined should tell, so that all over Karnataka, pedagogy becomes a movement in PG teaching and learning. And I think, Manjula, you are also assisted by Rashmi and Srimati and Sushma. Am I right?
Yes, ma'am.
Yeah, yeah. So they should also pitch in with all the efforts, I feel. I think, I'm sure they are also there. They are
Hmm.
also doing all the background work, I'm sure. So, one thing I wanted to request Rajeshri was, of course, medical colleges get the priority, but please include DNB institutions
Of course,
also.
of course.
So, because I have been a DNB teacher now for past 20 years. Earlier to that, I was MD teacher. So, I think that that will make a difference. Also, more numbers will come in. More
Ma'am,
people will benefit.
kindly send the list of the DNB
Yeah, we
colleges
have
so
in
that
KSOG Kane, you can take from Suchitra. We have.
so that along with this we can also add one DNB
Yeah, yeah.
colleges also and the
We will
students as
take
well.
the list from Suchitra because we have in Bangalore, when we
Sure.
do KSOG CME, she
Hmm.
has the entire list. I'm sure
Okay, ma'am.
all who do the state level CMEs, Hubli also
Hmm.
will have this list. Okay. All
Okay,
right
ma'am.
then. Thank you very much. All
Thank
the
you, ma'am.
best. God bless. God bless you for doing such a wonderful job.
So
Thank you so much.
before we go ahead, I think Manjula, I must put it on record that we have such promising, young, and very, very efficient brigade. That is Dr. Rashmi Patil, Dr. Srimati, Dr. Sushma, and you. And I'm so very happy that all of you have fallen in sync with this concept and have tried your best to give the best kind of support. Sushma, are you there? Please come on screen, dear.
I think she had a mocks meeting,
Okay.
so she was telling doubtful to join. If possible, she will join Anta.
And Dr. Rashmi?
She, Rashmi and
Yes,
Srimati
ma'am.
have joined.
Okay.
I'm
Hi,
here, ma'am.
Rashmi.
Rashmi,
Rashmi, we would like to see you. and we would also like to listen from you what you have to say about this.
Pedagogy is a wonderful concept, ma'am, and I'm happy you, Manjula ma'am, Sushma ma'am, and Srimati ma'am, everybody have taken this great initiative. Happy to be a part of it in this learning program for the postgraduates. Thank you, ma'am.
Yeah, we'll all work up together and form a competitive-based pedagogy test audience both, because
Yes, ma'am.
this was a kind of trial to see how the run goes, and we'll definitely have a proper scheme in place and rope in more students to join with experts from the next time who will be observing their performance and having a scoring system for the postgraduate students. So that is what we were discussing. Manjula had this idea, and unfortunately today we couldn't get much the senior experts, because they were held up in some of the other kind of commitments. And from next time onwards, definitely we'll see that it becomes a very, very intense performing concept.
Yes.
I think this is the first time anywhere such kind of pedagogy is occurring.
First of its kind. First of its kind.
So the first PG who is presenting here today will go and record and become the first person to do this. Over to you, Dr. Manjula, and thank you so much.
Thank you, Rajashri ma'am, for giving this responsibility. So I was very happy to start this and carry out. It was a very good experience to talk to all the HODs and to communicate and to convey all this.
Yes.
And from now onwards, we will make it more and more popular and more reachable to most of the PGs.
Fantastic.
So
okay, here we go.
Yeah, we'll start with the first candidate. Dr. Pallavi Naik, I request all the HODs to log in, and at the end of the talk, please convey your questions, convey your remarks, so that they are also can improvise on improvising their topics and understanding and the clinical aspects of it. So without much wasting time, we are going to start with the first candidate, Dr. Pallavi Naik Raichur.
Yes,
The
ma'am.
topic is on uterine inversion. Uterine inversion.
Okay. Shall I start, ma'am?
Yes, yes, yes.
Okay. So uterine inversion, it is a rare condition, but it is a life-threatening complication which is occurring during the third stage of the labor. It is the incidence is approximately it will show in a 1 in 8,000 to 1 in 28,000 deliveries. So depending upon the severity of the uterine inversion, it is classified as first degree, second degree, and third degree. In first degree, the fundus is just depressed. In second degree, the inverted fundus protrudes through the cervix. In third degree, the whole uterus, including the cervix, is inverted. It may drag the vagina and appears outside the vulva. Depending upon the timing of the event, it again classified as a acute, subacute, and chronic. In acute, within 24 hours of delivery. In subacute, after 24 hours, but within 4 weeks of delivery. In chronic, after 4 weeks of delivery. The main causes of the uterine inversion is the mismanagement of the third stage of a labor. While giving an excessive cord traction is given along with the fundus pressure on a relaxed uterus for the delivery of the placenta. And the other risk factors are the fundal insertion and morbidly adherent placenta, short cord, uterine atony, and uterine tumors. Usually, the inversion of the uterus is much more common in the cesarean section, but it is not reported because the minor inversions are easily corrected, and the major degrees of the inversions are bringing out the entire uterus out of the uterine incision. Although there is a standard recommendation that before the placenta should not be delivered before correcting the inversion of the uterus, but it will not may hold in the cesarean section because the bulk of the uterus and the placenta may prevent the reduction of the uterus. Diagnosis, the classical triad of the uterine inversion is the hemorrhage, shock, and the severe pelvic pain. Shock is mainly due to the traction over the ligaments which are supporting the uterus, which is causing a parasympathetic stimulation that is mainly due to neurogenic shock. And the shock may be due to hypovolemia as a result of an acute blood loss. Um, the on parabdominal examination, there will be a cupping, dimpling, or the irregularity of the surface of the counter. And on a bimanual examination, there will be the cupping of the fundus, or there will be a missing of the fundus. On pervaginal examination, there is a fleshy reddish mass seen outside the vulva in the third degree inversion. Prevention is the mainly correction of the mismanagement of the third stage of the labor, and we should not allow the removal of the placenta before correction of the inversion of the uterus. The management first, the main triad of the diagnosis, there is the hemorrhage. That's why we have to resuscitate the patient immediately with an IV large bore IV cannula placing, and we have to send in a blood sample for the cross matching. Along with that, we have to keep the patient warm, and we have to put the patient with an oxygen mask, and catheterization we have to do. And the most treatment is the immediate replacement without attempting to remove the placenta from the inverted fundus, which can be delivered later. If you are trying to remove the placenta without a correction of the inversion of the uterus, it may leads to an severe bleeding, because there may be a morbidly adherent placenta, or it may result in a maternal sinus, which are excessively engorged, and which leads to infection and bleeding, which may leads to aggravate the further already developing shock. Yeah.
So, Dr. Pallavi, could you put your video on, please?
Yes, ma'am.
Yeah. Let's have some basic rules for this pedagogy test.
Yeah.
One is that the video should be on, and second is we'll have a timer and put the timer to 5 minutes, so that in the 5 minutes the candidate should be able to complete.
Yeah, and ನಾನು ನೋಡ್ಕೊತಾ ಇದ್ದೀನಿ time. She started at 8:16.
Okay.
So she has one more minute to go.
Okay. Yes, Pallavi.
Yes, ma'am. We can use uterine tocolytics like terbutaline 250 microgram. If it is not manageable, then we can use a general anesthesia with an halogen. It will decreases the deep myometrial contraction of the uterus. The next method is the manual repositioning of the inversion of the uterus. That is the Johnson method. In this, we have to place the palm of the hand with the fundus of the uterus along the direction of the vagina, and we have to push towards the posterior fornix, and then we have to lift the fundus of the uterus towards the umbilical, so that it will be placed in its normal position. While doing it, we have to palpate the we have to use other hand over the per abdomen to see the counter of the uterus. And if we are failing this management, then we can go for an hydrostatic management. In this this is also called an O-Sullivan method. In this method, we'll use we'll infuse in a warm saline. We usually will take 2 bags of 1 liter of the warm saline. We'll infuse it through the vagina towards the posterior fornix with connecting in a white tube with one hand placing inside the vagina. Um, then surgical methods, we can use surgical methods like abdominal method and the vaginal procedures. In abdominal methods, the most important method is the Huntington method. In this Huntington method, first we'll identify the inversion of the.
Your time is up.
Okay. 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 So, Dr. Pallavi, how often do you see this? What is the incidence?
Ma'am, in India, the incidence is 1 in 8,000 to 1 in 28,000 deliveries, ma'am.
Yeah. What do you think has been able to control or prevent this inversion?
First thing is we have to manage the proper management of the third stage of the labor, ma'am. While giving, we should not give an excessive traction with excessive cord traction with an relaxed uterine fundus, ma'am. And we should not try to remove the placenta without correcting the inversion of the uterus, ma'am.
Okay. Okay. Thank you. That was, I think, she covered quite well in the given 5
Yeah.
minutes of time. And with that, I think we can move to the next candidate. Thank you, Dr.
Yeah.
Pallavi.
Congratulations, Dr. Pallavi. Good job.
The
Next, I would like to
Yeah, we give them some instructions like, please introduce yourself, the
Yeah.
medical college which you belong to, and which year PG you
Mm.
are doing. And then
Yeah.
you must
Yeah.
start with the topic and keep your video on, please.
MRMC Kalburgi, Dr. Shravani. Are you there? Shravani?
Yes, ma'am.
Dr. Shravani.
Yes,
Your
ma'am.
topic is on HPV vaccine. Please introduce
HP.
yourself, switch on the video.
Ma'am, this is Dr. Sharvani M. Patil from Mahadevappa Rampura Medical College, Kalburgi, ma'am. I'm studying as a final year postgraduate currently. So my today's topic is HPV vaccination. Human papilloma virus, it is a epitheliotropic virus.
Kelista idea. I think there is some disturbance, I think.
No, I think our audio is okay. Video is little blurred.
Yeah.
But otherwise, we are able to hear your.
Okay.
It is a human papilloma virus. It is a epitheliotropic virus. The main viral proteins which are required are for virus to epithelium attachment, the proteins required are L1 and L2. For viral replication, the proteins which are required are E1 and E2. For recombinant transformation, that is for malignant transformation, the proteins which are required are E6 and E7. E6 is for suppressor of the P53 gene, and E7 is for the suppression of the recombinant gene. The major HPV subtypes are the low risk subtypes are HPV 6 and 11, whereas the high risk subtypes are 16, 18, 31, 33, 35, 45, then 58. So the HPV vaccine, it is a inactivated recombinant vaccine which has a capsid protein of L1. There are ideal age for the ideal age for giving HPV vaccine is between 9 to 45 years of age. But according to ACOG, there is high efficacy when it is administered between 9 to 26 years of age. There are mainly three vaccines, that is bivalent, quadrivalent, and nonavalent. Based on the brand names, the bivalent is Cervarix, the quadrivalent is Gardasil, and the nanovalent is Gardasil 9. The bivalent vaccine, it covers mainly HPV 16 and 18. So it provides a protection against cervical intraepithelial neoplasia and cervical cancer. Whereas the quadrivalent, that is Gardasil, it covers the HPV subtypes 16, 18, 6, and 11. So it covers CIN, cancer cervix. Along with this, it also covers the genital warts. Whereas the nanovalent, that is Gardasil 9, it provides a protection against 16, 18, 6, 11, 31, 33, 45, 52. So it provides protection against cervical intraepithelial neoplasia, cancer cervix, vulval cancer, vaginal cancer. Along with this, it also provides a protection against cancers in the male, that is anal cancer and penile cancer. The dosage given is 0.5 ml, and the route is it is given intramuscularly. In the bivalent vaccine, in 0.5 ml, it constitutes both HPV 16 and 18. HPV 16 constitutes about 20 micrograms and HPV 18 for about 20 micrograms. Whereas in quadrivalent, that is in 0.5 ml, it is constituted as 16, 18, 6, and 11. In 16, it constitutes for 40 microgram, 18 for 20 microgram, 6 for 20, and 11 for 40 micrograms. So the dosage is 0.5 ml and the route is intramuscularly it is administered. According to age, if a person or a male or female is less than 15 years of age, the recommended schedule is it is given at 0th month and 6th month. Only two doses are recommended. If the age is more than 15 years or the person is immunocompromised, three doses are given, that is at 0, 1, and 6 months. It is administered and recommended both to boys and girls. The adjuvant which is used in the bivalent vaccine is alum sulfate, whereas in quadrivalent and nonavalent vaccine, we will use the adjuvant as alum. The efficacy of this vaccine, if the person is already exposed to HPV, then the efficacy is 19. Already exposed to HPV, the efficacy is 44%. If the person is not exposed to HPV, the efficacy is highest, that is 99%. The ideal age, according to ACOG, for administration of this vaccine is between 11 to 12 years of age. And the contraindications for providing this vaccine, if the person is pregnant, or if the age is less than 9 years, or there is any hypersensitivity reactions. The most common complication is syncope to the patient. So always we should advise them to take 15 minutes of rest after administration of this vaccine. The other side effects include injection site pain, swelling at the site of injection, or mild fever and malaise. But this vaccine is safe during breastfeeding.
Okay. So what is
I
the
think your
WHO
time is
concept?
up.
What is the concept of WHO of
Audio
1970?
is not clear, I think.
Shravani, you can hear me?
Yes, ma'am.
Yeah. What is
Yeah,
the
I think.
WHO concept of 90, 70, 90? What is the goal of the WHO? And is it possible to eliminate the cancer of the cervix? Are there
Ma'am,
any
by
countries who have eliminated the cancer of cervix already?
not yet, ma'am. By the 2030, 90% of the women should be screened for the cancer cervix, and 70% should be prevented. And at least 90% of the women who are treated, the treatment should be started for those women.
Correct. And there are some countries wherein the cancer cervix has been eliminated by giving the HPV vaccination, because it's a protocol in the vaccination right from the young girls. So Australia is one country wherein they have achieved that cancer cervix has been eliminated. And in India, we hope that, like the polio virus has been eliminated, if we follow this protocol and schedule, by 2050 at least, we will be able to take care of the cancer of the
Cancer
cervix.
cervix.
So, in government, what is the recently Prime Minister has advocated for the
Yeah,
immunization protocol. So, what is the vaccine given in the immunization protocol, and what is the dosage given there?
it is given
Ma'am,
throughout
mainly
India and all the PHCs. What is the guidelines followed in that?
the guidelines followed is mainly here we will use quadrivalent Gardasil, ma'am.
In
Cervarix.
My dear,
cervix,
government of India, sorry. Okay, Madi, you ask.
no. She was telling Gardasil and Cervarix, Allah. So,
Cervix.
Government of India is giving free of cost in all the PHCs, district hospitals. So, what is the guidelines in that? What is the age that they are considering?
Less than 26 years of age, ma'am.
No, dear, no. Who has completed 14 years, who has completed the 14th birthday, and who has not crossed 15 years. So, once who has celebrated the 14th year of birthday, they are eligible for the government supplied free vaccination throughout the country. And till May end, it was given, provided free of cost throughout the country. And from next month onwards, that will be provided in all the centers only on a immunization day.
Okay.
They have to give the role in their name and the age and the place and particular PHC. They should go and take the vaccine. It is given free of cost.
okay.
So well done, Shravani.
Thank you, ma'am.
Next, I call upon Dr. Sushma to call the next candidate.
Yeah, Shravani, congratulations. I think a little more touch up upon the age is very important, because now the WHO says that a single dose of vaccine is enough when you are giving at the age of 14 years of 14-year
Okay.
girls and 15-year girls. Okay.
Thank you, ma'am.
Okay.
And
Congratulations.
candidates, please give your
Thank you,
inputs.
ma'am.
If at all this has to be extended, the time, if the time is short, or If you think so, if we need to give more time, you please give the suggestions.
And we welcome your input in the chat box.
Yeah. Also, all the HODs, please give your inputs too. Dr. Sushma?
Very good evening, everyone. Am I audible?
Yeah, you are.
Yeah. First of all, it's a great honor that I'm working under the supervision and the guidance of Rajeshri ma'am. It's extremely academic and wonderful program, especially for the PG program. Because I was held up in the our mocks meeting. Pardon me for the delayed joining. We'll move on to the next candidate, Dr. Shivika Jindal from KMC Mangalore. Your topic is second trimester MTP. Over to you, Dr. Shivika.
Hello. Good evening, everyone.
Your audio is not.
Am I audible, ma'am, now? Hello.
Yeah, you're
Am I
audible.
audible now?
Yeah, tell me.
Good evening, everyone. I am Dr. Shivika Jindal from KMC Mangalore. I will be discussing about second trimester abortion. Second trimester abortion provides an important second trimester abortion has increased in recent years due to widespread use of prenatal screenings and anomaly scans, which allow detection of major fetal anomalies during second trimester. Second trimester abortion generally refers to termination of pregnancy between 13 to 20 weeks period of gestation. However, after MTP Amendment Act, termination may be permitted up to 24 weeks in the specific category of women. The indication can be broadly classified into fetal, maternal, and social indication. Fetal indication being lethal
I
congenital
think audio is not clear
malformation.
for me at least. I don't know about others.
Lethal congenital malformations, major structural anomalies, chromosomal disorders, and severe genetic disease. Maternal indication includes serious cardiac disease, renal disease, malignancy, requiring urgent treatment and condition where continuation of pregnancy poses a significant threat to maternal health. Social indication includes pregnancy resulting from rape, incest, and contraceptive failure as recognized under MTP Act. Before undertaking termination, a thorough evaluation is essential. Gestational age should be confirmed by ultrasonography, hemoglobin estimation should be done, blood grouping and RH typing should be done. Equal importance in detailed counseling regarding the procedure and possible complications and future contraceptive planning should be done. The method of second trimester termination can be divided into medical and surgical. Medical methods are currently the most preferred in most settings.
I
The
think you
most
guys are reading the PPT. Please don't read that. This is an oral because this will be like your examination wherein you are facing the examiner and you're talking. The very exercise concept of this is to make you prepare for your examinations. So if at all, if you follow the instructions, it will be very beneficial for you.
No, ma'am, I'm telling. Yes.
Right?
The medical.
Okay, continue.
The medical methods that are there is based on the FIGO and FIGO screening
Okay,
protocol.
continue.
The most effective regime consists of mifepristone followed by misoprostol. Mifepristone is given 400 as 200 microgram per oral. 200 microgram per oral. After 48 hours, misoprostol can be given. That is given after 24 to 48 hours. Misoprostol is administered,
No, I
which
think
helps in survival.
Manjula, the candidate must face the camera.
Exactly. That is
They
ಅದಕ್ಕೆ
have
ನಾನು
to face
ಹೇಳಿದ್ದು
the camera.
camera
They have to look at the
ಅದು
camera and speak.
yes
Right?
actually you should see front, yeah, like this. Now you are seeing at me, no, like that you should see.
Okay,
You
ma'am.
are, it
The
is very
misoprostol.
much evident that
Otherwise,
you
your
are presenting.
presentation will not be acceptable. It will not be
Yeah,
acceptable.
because idrinda it is not going to benefit, dear. See, the purpose is to
Ma'am,
make you people prepare mentally for your exams. Once you start doing this exercise, later on it will become easy and you will be mentally prepared for other topics too. So that is the concept. ನೀವು ಸುಮ್ಮನೆ ಹಿಂಗ್ ನೋಡ್ಕೊಂಡು ಪ್ರೆಸೆಂಟ್ ಮಾಡೋದಿದ್ರೆ it is of no use. I know it is online, but still if you are honest, it is good for you only. No? See, you will have to memorize the points also before coming. That is the all the purpose of this. It is just not for casual
It is not extempore anyway,
presentation.
Alva. It is
You have
not
to look at
extempore,
us.
no?
Yes, ma'am. Ma'am, mifepristone can be given 200 microgram per oral. after
Manjula, it is not extempore, no?
Ma'am,
Candidates,
pedagoginally they have
it is not
to.
extempore, no?
It is like oral presentation,
Topic,
ma'am. They have to
topics have been given to
pick
them,
the
Dr.
topic
Shobha.
and they have to.
No,
Yeah.
no, it is not extempore, no? They have been given the topics.
Yes.
Yes. They have given the topic earlier.
Then they must speak without looking, no? They should look
ಅದನ್ನೇ
at
ನಾನು
the
ಹೇಳ್ತಾ ಇರೋದು.
camera only.
That's what I'm telling them.
Yeah.
Yeah. Yes. Okay. Okay. Continue, ma'am.
Mifepristone can be given in 48 hours and followed by which misoprostol is given after 24 to 48 hours in 200 microgram per oral. 200 microgram per oral sublingual buccal until expulsion every 3 hours until expulsion. After medical methods, in some FIGO also have given only misoprostol only regimen, but in misoprostol only regimen the induction to delivery induction to expulsion interval is more as compared with mifepristone plus misoprostol. Other methods that can be used is historically that was used was extra amniotic saline infusion and ethicrine infusion. But these methods have more side effects, like they can lead to infection, they can lead to hyponatremia, and thus can lead to other complications. Now, talking about the mechanical methods include the Foley's induction. Foley's induction can be done with 30 ml saline, which helps in expulsion of the fetus, following which if medical and mechanical methods also fail, it can lead to, we can also try surgical methods, which is suction and evacuation can be done in early pregnancies, in early second trimester, and after that, if still fails, hysterectomy can be done. Post abortion, the care is complications include infections, then infections, chances of retained product of conception, bleeding. So post-abortal care should be taken. Check scan is done after 6 weeks period of after 6 weeks. Then if Rh negative pregnancy is there, then NTD should be given to the woman of 150 microgram. 150 microgram. Second trimester, now the recent update is MTP Amendment Act. In this, till 20 weeks period of gestation, one registered medical practitioner can opine and give MTP. Till 24 weeks, two registered medical practitioner is allowed. After 24
Sushma,
weeks,
are you
medical
keeping the
board is
timing?
recommended.
I think her time is up. Sushma, are you there? Okay. I think your time is up. Yeah.
Okay.
What are the indications that you are doing hysterectomy in second trimester?
Ma'am, if after 24 or 20 weeks we have tried medical management, still it is not this is not expelling, then we can do hysterectomy, or if any other medical indication is there, like severe preeclampsia where we don't have time, that time we can do hysterectomy.
How many of such cases have you come across?
Ma'am, we do hysterectomy, ma'am.
After MIFI and MISO, I don't think so.
So, ma'am, we have given try
correct,
for
no?
cell.
So, yeah, because
if any malpresentation is there, ma'am, like transverse lie and all that, there also hysterectomy is preferred. If by chance, if it's like estimated fetal or
In a prior
but,
scar, what is the protocol?
in previous cesarean section, ma'am, we have to take care for scar tenderness. Scar tenderness shouldn't be like scar tenderness, pulse rate, impending rupture. We have to take care because we are giving misoprostol. Misoprostol is releases prostaglandins, which leads to uterine contraction. Thus can lead to uterine scar rupture.
Rajashri, ma'am?
Yeah, I think, you need to specify as to what are the special, now we have the inverted pyramid concept, right? by 12 to 14 weeks, we are able to identify many of the anomalies that
Yes,
are
ma'am.
going to be known, and only it is the severe kind of anomalies, maybe the cardiac or the cranial kind of anomalies. So the indications as such for second trimester have now narrowed down very much. Once you have diagnosed, then the counseling becomes very important as to how you're going ahead with the medical termination of pregnancy, and have very, very specific indications and the weeks of gestation. Okay, the weeks of gestation has to be very, very clearly identified, and it has to be mentioned.
Arun, can you
If you
mute
are
the
doing
person, the
yeah, somebody
one who's like, there is too much of disturbance from one person? Can you mute that person, please?
can we request the others to mute themselves, please?
Yeah,
Uh,
just ನೋಡ್ಬಿಟ್ಟು ಅವ್ರದ್ದು ಯಾರು ಡಿಸ್ಟರ್ಬೆನ್ಸ್ ಇದೆ ಅವ್ರನ್ನ ಮ್ಯೂಟ್ ಮಾಡ್ಬಿಡು.
Madam, from Sushma
I
madam,
think it got.
Sushma
ನೀನ್ ಮ್ಯೂಟ್
madam,
ಮಾಡಪ್ಪ. ಸುಷ್ಮಂದ ಡಿಸ್ಟರ್ಬೆನ್ಸ್ ಇರೋದು?
yeah, ಅವ್ರದ್ದೇ ಇರ್ಬೋದು.
ಓಕೆ. ಸೈಲೆಂಟ್ ಇದೆ ಅನ್ಸುತ್ತೆ. ಓಕೆ ಓಕೆ, ಇವಾಗ ಇನ್ನೂ ಯಾರ್ದೋ ಗೊತ್ತಾಗ್ತಿಲ್ಲ ನನಗೆ. ಎನಿವೆ ಮ್ಯಾಮ್
ಈಗ
ಕಂಟಿನ್ಯೂ
ನೋಡ್ರಿ
ಮಾಡಿ.
ಮೇಡಮ್.
Yeah, this is better now.
Sushma madam.
ಬೆಟರ್.
Okay, so Shivika, the
Okay.
indications for the medical termination of pregnancy, especially when you're going for beyond 20 weeks and 22 weeks and 24 weeks. So what are
Ma'am.
the specific situations wherein you go for MTP at 24 weeks? What new, the late onset defects can come up? And what are the
Ma'am,
precautions
this,
you need to
like,
take?
Ma'am, with the onset of with the onset of anomalies, like on detailed anomalies, can some cardiac anomalies or anomalous fetus, there we can take MTP. We can go to medical board and we can help in
At
this.
which period you go to the medical board?
After 24 weeks
After
period of
24 weeks. And who are the people constituting the medical board?
people constituting the medical board, ma'am, registered medical practitioner, obstetrician, radiologist, pediatrician, ma'am, and then medical officer, government medical officer, they constitute medical board, ma'am.
So I think most of it she has covered, but there has to be a clarity and spontaneity about the presentation, and also the incidence of MTPs. How many cases are going for medical termination and complications of MTPs?
Yes, ma'am.
Very rarely there could be cases of embolism, but you should keep in mind that such things can happen even with the second trimester medical termination of pregnancy. Thank you. Congratulations, Shivalika.
Thank you.
Thank you.
Thank you. Next, I call upon KMCRI Hubli, Dr. Deepthi. Your topic is on POXO Act. Dr. Deepthi, are you there?
Yes, ma'am.
Introduce yourself.
Am I visible, ma'am?
And then start. Yeah, ma.
Yeah.
You are.
Good evening, ma'am. I'm Dr. Deepthi Hesrur. I'm a third year postgraduate in KMCRI Hubli. My topic for today is POXO Act. Every year, according to National Crime Bureau of India, 39,000 of POXO cases are registered, with an incidence of 190 cases being reported every day and 8 cases being reported every hour. POXO Act was introduced in the year 2012 on November 14th. This is a child-centric, gender-neutral act which focuses on prevention of sexual harassment, sexual assault, and in prevention of child digital pornography. The provisions of the Child POXO Act is the definition of a child according to POXO Act is any person below the age of 18, irrespective of gender. According to the Act, it is implied that a person below the age of 18 cannot consent to an act of coitus. The different sections of the POXO Act are: Section A defines sexual assault, that is any sexual assault, and the punishment for this is 10 years to life imprisonment. Section B is penetrative sexual assault, which is using of forceful object or sexual assault by a person in position of power, like the principal of a school, doctor, or an army personnel. For this, the punishment is 20 years to life imprisonment. Section 3 is sexual harassment, that is using of vulgar gestures. Section 4 is sexual assault itself, that is either by messages. And Section 5 is digital use of child's photographs for digital pornography. The imprisonment for this is 3 to 7 years. According to POCSO Act Section 21, it is written that mandatory reporting of all cases of child sexual abuse should be done by any person who is aware of that. Failure to report an act of child sexual abuse can lead to an imprisonment of 6 months. The main provision is the sections 18, which is the medico legal examination. Medico legal examination should be done in a child friendly manner, preferably done by a woman doctor. If no woman doctor is available, then a doctor will be appointed by the state in the presence of the guardian. The samples that should be collected during medico legal examination are clothing of the child, nail scrapings, fingernail scrapings, then hair clippings, then cervical swab, high cervical swab, vaginal swab, and even pubic hair clippings. Uh, the main provision of POCSO Act is also the child-friendly nature of the procedure, which is the statement of the child is recorded in the residence of the child if the child insists. It is done in the presence of a female police officer, and the police officer need not be in their uniform during the recording of the statement. The accused should not be in the same room during the recording of the statement, and ideally recording should be done within 24 hours of the act or within 24 hours of reporting. POCSO Act emphasizes on specialized courts in each district, which should be headed by a woman judge to facilitate easy judgment, and the trial should be completed within a span of 1 year. Within 30 days, at least a court date should be set for the allocation or examination of the child. The current recent updates in POCSO Act is in the year 2019, the provision for aggravated penetrative sexual assault, the punishment changed from life imprisonment to death. Currently, a 6-member Supreme Court bench is debating the lowering of the age for a child according to POCSO Act from 18 to 16. This is because of increase in consensual relationships between older teenagers of the same age group. Thank you, ma'am.
Should the child be accompanied by somebody when she's going for reporting?
During reporting, preferably by a female guardian, ma'am, in their presence. If the child insists, then even if there is, it is not a compulsion.
The parent has to accompany?
No, ma'am, it is not
Anybody
compulsory.
who is there. Okay.
Yes, ma'am.
If the girl comes to you less than 18 years, say 17 years, with
Yes,
lower
ma'am.
abdomen pain
Yes, ma'am.
and delayed cycle, what is
Yes.
that you're going to do?
A urine pregnancy test, ma'am. If first test in case of any history of amenorrhea, I'll check for urine pregnancy test, ma'am.
So, what if UPT is positive?
UPT is positive medico-legally, I'll register a medico-legal case. I'll alert the POX. I'll register an FIR, but the treatment should not
What
be
is the first thing you do once the UPT is positive?
confirm whether it is intrauterine pregnancy or an ectopic pregnancy, ma'am.
Then?
If it is an intrauterine pregnancy or if it is a live intrauterine pregnancy, if cardiac activity is present.
Then?
Then register an MLC.
Who is going to register MLC?
The chief medical officer in that hospital should register an MLC, ma'am.
What is your duty? You are a doctor.
To report.
Patient just comes to you. What is your duty once you see that under 18 years of age, she is UPT positive and the pregnancy is confirmed? What is your immediate step?
Mandatory reporting, ma'am, to the police.
First thing is to report to the police, irrespective of whoever it is, whatever it is. You don't have to tell to the parents that you are going to report to them.
Yes, ma'am.
You don't have to tell to the patient or the parents or the attenders who has come to you with. You just have to take the nearby police, what is the jurisdiction that you are working, that police, you have to inform that such and such a case has come. And
Yes, ma'am.
then they will do the formalities. You
Yes,
just
ma'am.
have to treat what is needful to the patient. You are not going to do MLC, you're not going to do all those formalities. That is done by the police. You just
Yes,
have
ma'am.
to inform. Informing is mandatory. What if you're not going to inform?
6 months imprisonment according to the act, ma'am.
Yeah, that is the punishment that you're going to give. Once the patient has come to you and you have known that she is UPT positive, it is mandatory that you should supposed to inform to the police and do the needful according to the whether she wants to continue or she wants to she does not want to continue, then it is the whatever the treatment she wants to continue, that you have to carry out, but other things has to be carried out by the police.
Yes, ma'am.
Any of the faculties, HODs would like to ask questions, please. You can raise your hand. And Rajeshri ma'am.
Yeah, I think she's. It's a very, very dicey situation to be in a POXO Act. And even a married girl who is less than 18 years of age, if she comes with pregnancy also, she comes under the POXO Act. So this is a very debatable situation, as in how are we going to supplement or how are we going to defend this girl? And it's mandatory that we need to have the Aadhaar card. Aadhaar card with the girl whenever she comes, and you know
You
that
have to confirm the age of the patient with Aadhaar card.
Yes, ma'am.
so
That is
having
also
the Aadhaar
mandatory.
card and confirming the age is very, very
Yeah.
mandatory. And even if there is a pregnancy less than 18 years of age, and you know, even if she, at the time of pregnancy, she's 17 and she becomes 18
Now
at the
she's
time of
18.
delivery also, then you will have to
Yeah.
report her. So such are the scenarios where we have to be very, very
Yeah.
alert and
We
very, very
currently have a
cautious.
patient, ma'am, who has
Yes.
conceived at 17 and now she's 18.
She's in 18. So we know how tricky the situation is and how difficult it becomes to defend such girls. And then in a busy clinical practice, having the private practice, and then you end up doing such things, and it becomes a real situation for all of us.
Yes, ma'am.
But nevertheless, we have to be very defensive because the medical legal aspects are very stringent, and we need to follow the protocols and report to such cases also. Okay,
Yes,
well
ma'am.
done. Well done, Deepti.
Thank you, ma'am.
Well done, Deepti.
Thank you, ma'am.
Dr. Sushma.
We'll move on to the next student, Dr. Shravya from BMC. Your topic is on HRT.
Good evening, respected delegate. I'm Dr. Shravya from BMCRI. I'll be talking on hormonal replacement therapy. Hormonal replacement therapy is usually started for women who have attained postmenopause or who have attained premature postmenopause age. So in hormone replacement therapy, usually we'll be starting with conjugated equine estrogen, that is Premarin, which is used as a lower dose, that is 0.3 mg. If a patient has
no, I would like to interrupt here, Shravya. What is the age at which you can start the hormonal replacement therapy? Is it mandatory that the woman should attain the menopause, or can you start it around the perimenopausal age? When do you consider it as a perimenopausal age, and how do you select the hormones for replacement?
Ma'am, usually when a patient presents to us with complaints of vasomotor symptoms and urinary symptoms and vaginal atrophy, usually they may present around 40 to 45 years of age group. At that time, we usually start with conjugated equine estrogen, lower dose of 0.3 mg. If the patient still have uterus remaining, there is increased chances of endometrial cancer with only use of estrogen. So we usually pair it up with progesterone, that is medroxyprogesterone acetate, 2.5 mg can be added with estrogen, ma'am. Usually around 40 to 45 years we start it, ma'am.
Okay, anything else?
Ma'am?
Anything else? Is that all?
Ma'am, if the patient presents with vasomotor symptoms like hot flushes, and if she presents with urinary incontinence or any vaginal complications or any vaginal atrophy and with itching pruritus vulva, in that cases we can start with HRT, ma'am.
Up to what age can you give the HRT?
Ma'am, it is usually given for 5 years.
ಅವಳು ಇನ್ನೂ ಪ್ರೆಸೆಂಟ್ ಮಾಡಿಲ್ಲ.
ಹೌದು. Has she completed her presentation?
ಇಲ್ಲ ಮಾಡಿಲ್ಲ.
ಮಾಡಿ. Go ahead.
Yes, ma'am. Thank you, ma'am. We'll be starting with estrogen and we'll be pairing up with progesterone. We counsel the patient about the complications of the hormone replacement therapy initially. And what are the indications to start HRT? As I already said, we usually start to the women who have vasomotor symptoms and who have anal pruritus vulva. We don't start the HRT for treatment of cardiac diseases. It is not a primary or secondary treatment for cardiac diseases. And for patients who come with a history of dementia or treatment for dementia, HRT cannot be used. And what are the absolute contraindications for HRT? If a female presents with unknown cause for abnormal vaginal bleeding, then HRT cannot be used. If a female gives history of breast cancer in the family or any estrogen-dependent cancers in the family, then HRT cannot be used. And if the patient also complains of previous history of thromboembolism or any history of stroke in the previous 1 year age, 1 year before starting HRT, then also HRT cannot be used. And other relative contraindications are if the patient has any gallbladder disorders, or if the patient has endometriosis, and if the patient also complains of DBT or anything, then previous history of thromboembolism or stroke, then we usually don't give HRT. And the routes of administration of HRT, usually oral formulations are used. In oral formulation, if the person still has uterus, we usually give estrogen and progesterone combination, usually conjugated equine estrogen, that is Premarin, with medroxyprogesterone acetate is used. If we are giving it in a continuous basis, medroxyprogesterone is used as 2.5 mg daily for 28 days. And then we give withdrawal for 5 days, that is cyclical HRT is given. If we give medroxyprogesterone from day 18 to day 28 of cycle, then 5 mg is given. After the other combinations which can be used are with conjugated equine estrogen, we can also use micronized progesterone, that is 200 mg BD can be used, or 100 mg BD can also be used. The other newly used are Yasmin, that is estrogen 30 microgram with droseparon. Droseparon also, it is a third generation progesterone drug. It also has an anti-mineralocorticoid activity. So the side effects of progesterone, that is edema and weight gain, can be reduced by using droseparon. The only thing is it is a bit costlier compared to the other drugs. And the other treatment which can be used is with oral HRT, there are increased chances of first pass metabolism. So the drug effectiveness is usually reduced. So there are other formulations of using HRT, that is transdermal gels can also be used, or transdermal patches can be used, which contains estrogen and progesterone. It is usually changed twice in a week. And then the transdermal gels can also be used. If a patient complains of pruritus vulvae or dryness in the vagina, then local application of estradiol and estradiol creams can also be prescribed to the patient. And the other formulations are vaginal pessaries can also be used, and vaginal tablets are also available, that is progesterone and estrogen can also be used. And the other complications of with using HRT for a long time, the other complications are patient can end up with endometrial breast cancer sometimes if they don't give the history properly. If only estrogen is used, then the chances of endometrial cancer is also increased. Then there is no protection against cardiac diseases, and there are increased risk of venous thromboembolism also with use of HRT. So HRT is usually given for 5 years of 5 years.
I think your time is up.
Yes, ma'am.
Rajeshri Keli questions.
HRT, one thing we need to remember is that within 10 years of menopause, okay,
yes,
perimenopausal age group can be started from the age of 40 years and doesn't give any special benefit if you give around after the age of 60 years. So
yes,
whatever maximum benefit we have to give for the patient is around the age of menopause and within 10 years of onset of menopause, beyond which it's of doubtful value. But the amount of motivation that is needed for the patient to go for HRT replacement is really high because our women are not approachable. But for symptoms significantly like the night sweats or the mood swings and hot flashes, it has definite role. There are some people who have been taking HRT for 4 years, 5 years, 6 years like that. But along with HRT, it becomes mandatory that we advise them the lifestyle changes and all the kind of other palliative treatment and medications which are necessary, and the counseling and the the psychological counseling plays a very important role mandatorily. And we also have other non-hormonal therapies like HRT, because as you said, HRT cannot be used over a prolonged period of time. And what is the monitoring that we need to do for the patient when we are using the HRT? Do we need to do the frequent monitoring in terms of the blood investigations, to do the ultrasound evaluation, and to do the breast examination? Because anything it's a double-edged thing. So, you can't take it for granted whenever you're initiating a medication. So all these things have to be kept in mind and have to be used, because the treatment that you are going to give should not be causing her harm. Okay? So that is about the HRT. Okay, Shravya, well done.
Well done, Shravya. Students, any inputs that you would like to give, you can please convey it. Pallavi, Shravani, Shaivika, Deepthi, Shravya. Any inputs, any comments, any critics, you're most welcome. Any improvisation, you please convey it.
I must say that all the students have been very bold. They're very brave. They're very smart. They're very learned, and it takes an amount of the spark of the memory, that to recollect and conceptualize everything in a given frame of 5 minutes of time, not knowing. Although we have given you 5 questions each from obs and gynae, which effectively means 10 questions for you, and not knowing who will get which question, you have done very well, extremely well. And I heartily congratulate all your faculty and all the students for being such a good sport and taking part in this pedagogy, the first of its kind in KSOGA. And I hope that more will be benefited, and the number of beneficiaries will keep on adding up. There is a question from Mary Jane. Mary Joan? She has raised her hand.
Hello, ma'am. Yes, ma'am. Regarding POXO, ma'am, I would like to put one question. Most of the time in Raichur, ma'am, in Raichur, a patient will come with periods. They'll be having periods, and in such cases, they'll be like incident so happened that the samples could not be taken, ma'am. Hello, ma'am. Am I audible, ma'am?
Yeah. But every effort has to be done to collect the sample as much as possible, because the importance is to collect within the 24 hours.
Yes, ma'am. It so happened that they'll come with periods, ma'am. So in such cases, we should take samples, or we should call them after 1 week, or when the menstrual periods.
You should go ahead and take whatever samples you can get from the affected person, as in the clothes, the intimate clothes, and whatever is there on the
hairs, nails, pubic hair.
You need to document that the patient is menstruating also.
Yes, ma'am. Oh, that is one. Yes, they'll be presenting in labor room, ma'am, such cases.
The presence of seminar sperms in everything, the other contributory evidences that to the violence.
Okay.
So other evidence should be documented more meticulously.
Okay. Yes, ma'am.
90% of cases, you will not be getting a positive referral from the FSL.
Yes,
So the corroborative and the history will add to the information.
Yes, ma'am. So, apart from the vaginal and cervical sample, we should document rest all samples, right, ma'am?
Yes, you have to document any other external evidence of any force or something should be documented, and the what is the girl's mental status, everything to be documented.
Okay, ma'am. Thank you so much.
Sometimes they'll be influenced, and whether she's in a state to give. So all those things to be properly documented.
Okay, ma'am. Thank you, ma'am, for the
Rashmi, are you there? Rashmi, are you there? Rashmi, are you there?
Dr. Rashmi? Okay, I think with that we timely wind up the session. We had decided for a 1 hour session, and I think being first day and with one candidate being absent, but still we could make it up. And I think Dr. Rashmi has come up on the screen.
Yes, ma'am. Wonderful presentations by everyone, and great work done by Majula ma'am, Rajashri ma'am, Sushma ma'am. Thank you so much for encouraging all our students.
Thank you.
And most
thank you, students. Wonderful participation. Thank you.